So what we're going to talk about today are kind of causes and symptoms of head injury. If you follow the news and follow the NFL or any sports, you know that concussion is kind of a hot button issue today. The brain is enclosed in a vault, the skull. That's a good thing. That means we can hit our head and not hurt our brain. Now, if I hit my arm, my leg, my face, I bruise it, not really a huge deal. It will heal and get better. Brain, not so much. So the brain's enclosed in a vault to protect it. But let's go back to that injury on another body part. If I injure some body part, what does it do? It swells. That swelling is fine. It's a normal part of the reactive hyperemia or increased blood flow that comes with an injury. Now I've got the brain. Brain's in a closed box. Brain swells in response to injury. What happens? The brain pushes against the skull. The blood vessels are on the surface of the brain. Those blood vessels get crushed by that pressure, and what do you get? Infarcts. You get strokes. So the swelling of the brain in response to injury is dysfunctional. So in an open head injury, that's not an issue. The skull's been broken open by the trauma, the brain swells, you don't see that phenomenon. But in a closed head injury, you do. We'll talk about closed head injury today. What is the Monroe-Kelly hypothesis? What you see right here. At the top, dark blue is blood in veins. Red is blood in arteries. Salmon color is the brain. Orange is spinal fluid. All those compete for space in the closed vault of the skull. Now, you then have something that happens. Swelling, tumor, hematoma, what have you. And you introduce the purple area. That's the mass or the disease. What happens? Some of the venous blood gets squeezed out, some of the spinal fluid gets squeezed out, the brain is still doing fine. That's the compensated state. The brain's in trouble, but it's doing okay. Then you get to the decompensated state. The mass now occupies so much space, you've squeezed out all the spinal fluid, you've restricted blood flow, and then problems occur. So as you think about closed head injury, you want to keep this concept in mind. The brain is in a vault. The vault is a good thing. It protects us. However, the vault becomes the problem in closed head injury once you reach the decompensated state. Okay? So when that happens, the brain has to regulate blood in, blood out perfectly every second. It's called cerebral autoregulation. In trauma, that cerebral autoregulation gets jostled, and so blood in, blood out doesn't match. That's a bad thing. Now, what are the high-speed scientific terms you have to hear if you're at a medical lecture because it makes me feel smart to say them? All right? Cerebral dysautoregulation. That means the blood flow going into and going out of the brain is not matching minute for minute. Glutamate release. Glutamate is an excitatory neurotransmitter. It is preferentially released in trauma. It's a dysfunctional response. It makes the neurons react too much. They use up all their energy, all their ADP and ATP, and then they don't have energy. And then they have real problems. Neurons have to have energy constantly. That's why strokes are so sudden and so bad. Direct neuronal loss is not a real problem for most of what we'll talk about today. You really have to have very significant trauma. Think boxers, think NASCAR racers to really have direct neuronal loss. Glial loss. The neurons are so specialized, all they do is think. They can't do any of the other things that cells do. So they have helper cells. Those are glial cells. The glial cells support the neurons and do all the other jobs the neurons are supposed to be doing, but all they're doing is thinking. If the glial cells get damaged, then nobody's helping the neurons. By secondary effect, the neurons do poorly. That can happen in trauma. The glial cells are sensitive to impact. Secondary insults. Again, this would be in very significant trauma, but low blood pressure, low oxygen tension, other metabolic problems like blood sugar too high, too low, those things all contribute to a metabolic cascade that can turn a small head injury into a big head injury. And then finally, intracranial hemorrhage. Second impact syndrome. This is really where the meat and potatoes is when you talk about concussion. Frankly, the brain can take one hit and do pretty doggone well the vast majority of the time. It's when you pile 2, 3, 4, 5 hits on the brain in short order that the brain gets in trouble. We'll come back to that point over and over here in the next few minutes. So, closed head injury basics. Most of them you don't have to worry about. Repeat closed head injury is your big concern. Don't overtreat. We'll talk about overtreatment. Remember, hospitals are dangerous places. Doctors are dangerous people, okay? You want to kind of stay away from them if you can. So, know when to worry. And the answer to that is not always, okay? So the sky's not falling. Now, when do you worry? Everybody likes checklists. These are good things to write down if you're writing things down. When do you worry? Somebody's bonked their head at home. Somebody's bonked their head at school. Somebody's bonked their head at work. When do you worry? These are some good, relatively inclusive checklists to kind of focus on. Number one, loss of consciousness greater than 10 seconds. If you think about it and just count to 10 seconds, it's a long enough period of time that you're not wondering whether it happened or not. If somebody's unconscious for 3 or 4 seconds, you'll get disagreement as to whether they were unconscious or not. But 10 seconds, if they're out, and you'll know it. Altered mental status. No ifs, ands, or buts there. This person isn't thinking clearly. Perseveration. Mom, what time is it? It's 2 o'clock. Mom, what time is it? It's 2 o'clock. Mom, what time is it? It's 2 o'clock. Perseveration. Over and over again. They're not absorbing what you're telling them. Pupillary asymmetry. I've got a picture of that. We aren't used to looking at each other's pupils, but in a head injury you want to do that. You hold the eyes open, you get a bright light in there, and the pupils should look about the same. Focal deficit. Pretty obvious. Part of their body isn't working. Very, very straightforward. Vomiting or nausea. A lot of people will have some nausea after head injury. If it progresses to significant nausea where they can't keep anything down or they're actually throwing up, that's a warning sign. Blood thinners present. If somebody is on a blood thinner and they hit their head real hard, there are several very good studies that show their rate of progressive intracranial bleed in a delayed fashion up to 24 hours out is as high as 20%. So, somebody on blood thinners hits their head real hard, warning sign. Prior significant closed head injury. Again, somebody who's bonked their head before just bonked their head again. Something to worry about. CSF leak. Cerebrospinal fluid is the clear water that surrounds the brain and bathes and protects it. If it's leaking out, it looks just like a water faucet. It can come out the nose, it can come out the ear. It looks just like water. After significant trauma, you have somebody who says, my nose is running all the time. First thing a neurosurgeon has them do is lean forward. You'll see a water faucet come out of their nose. So, something to notice there. Symptoms that would be a warning sign is all. Not signs, but symptoms here. Severe headache. We all have headaches. How do you differentiate between a regular headache and a worrisome headache? Well, there's a lot of leeway there. But a headache that won't go away, that's debilitating after a head injury, you want to worry about it. Amnesia. People will often have a small amount of peri-event amnesia after they hit their head. But we'll talk about ways to test amnesia, but significant amnesia you want to worry about. Cognitive changes, again, we mentioned that, not thinking clearly. Decreased reaction times, something that you know they could do quickly. Count 10 $1 bills, button buttons, cut your steak with a fork and knife. They can't do that or they do it really, really slow. All right, fatigue, they're tired all the time. Vestibular imbalance symptoms. They'll tell you, I'm dizzy, the room's spinning, I can't walk in a straight line, okay? So, we've covered political and social issues quickly, the pathophysiology or how closed head injury affects us, and the clinical data. Now let's break it down by age group. Little kids. Everybody knows little kids have big heads and little bodies, okay? The way we say that in medicine is unique cranial somatic proportions, all right? What this means is when they fall, they're falling a very short distance because they're short. They're the last one to know if it rains. But when they go down, what happens? That big head is going to hit. Now, thankfully, kids haven't learned to tense up. That's a bad response when you fall. You want to be limp. Most of the time they'll fall, they'll be limp, and that saves them a bad injury. But they got a big head, and it hits hard. Unmyelinated brain. Myelin is the protein that surrounds the brain, the neurons, I should say, in the brain, and helps them have insulation so they send electrical signals back and forth more efficiently. The child's brain is not myelinated. Therefore, it is more susceptible to injury because it doesn't have that protective sheath around it. Difficult cognitive exam. You can't ask an 18-month-old, how are you feeling? Do you feel nauseated? You know, they're not going to get that. Poor physiologic compensation. What do I mean by that? If I took one of you and put you under tremendous physiologic stress and you needed more oxygen, your heart would do two things. It would beat faster, tachycardia, and it would increase stroke volume, meaning during diastole, the heart would relax more and allow more blood to come into it so it fills more and then pump more blood with each stroke. So the heart has two mechanisms by which it's going to help. Now, little kids, their heart is so small, all they can do is beat faster. They can't increase stroke volume. So the heart beats faster, 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 and then they just fall off the cliff. And so you'll see that with kids physiologically. They have very poor compensating mechanisms beyond a certain point. In little kids, remember, they can fall down, go boom, but always consider assisted trauma. Always consider whether an adult did something to that kiddo. Beware of unwitnessed events and physical impossibilities. I've been in emergency rooms where people told me this 2-year-old was climbing on a ladder. 2-year-olds don't climb on ladders, okay? All sorts of things you'll hear that aren't quite right. So think of those things as you look at closed head injury in an infant or toddler. This is the group where you exercise your greatest concern. They can look really good, really good, really good, and then just fall off the curve. And so you want to be aware of that when you think of closed head injury in a little one. When do you worry? Again, we've seen this list before. We'll see it several times with modifications for each demographic. Loss of consciousness greater than 10 seconds, altered mental status. Little kids have a fontanelle up until about age 14 to 20 months, depending on the kid. Nice soft spot here. That's a pressure window on the brain. It should be slightly sunken and even pulsatile. If it's full, you have a problem there. You need to get to the emergency room. Pupillary asymmetry. Here's a great picture. This is chemical pupillary asymmetry, not from trauma, but you see one pupil much, much bigger than the other. Very, very obvious. Focal deficit, again, part of the body not moving. Vomiting or nausea, kids throw up. You feed them too much, they throw up. So it's a hard one on that one. What I have decided over the years, if I have a child where we're suspecting a head injury, we feed them a little less. I'd rather have them crying and hungry than feeding them just to the point that they ralph it all back up and then I'm not sure what's going on, okay? So, prior significant closed head injury or congenital defects also should lower your threshold for being worried about a closed head injury in an infant. What do you do? Well, look at this first sentence. It's important. Healthy child, witnessed event, no warning signs, responsible parents. If you got all 4 of those ducks in a row, observe them for 24 hours, frequent wake-ups, reduce volume of intake so you're not making them throw up but feed them too much, see how they do. If you don't have all 4 of those, you probably need to be extra careful. The phrase we used to use in residency is if mom and dad have more tattoos than teeth, admit the kid. All right? It's just this nice, simple rule of thumb. So, any other scenario that doesn't fit those 4 right there, seek medical attention. Why don't you always just run to the ER every time your kid hits his head? Well, bottom line is most parents are smarter when it comes to their kids than most doctors. You know your kid, you know what's abnormal and normal and so on. Keep that in mind. Remember that the CAT scan, which is the go-to test in the emergency room for head injury, has a lot of radiation to it. Does that radiation damage the juvenile brain? Nobody really knows. It's probably, again, an overstated risk in the literature, but it's there. And what is the big risk of little kids in hospitals? Medication dosage errors. You dose medications in little kids milligrams per kilogram. Drop a decimal, add a 0, whatever, it can happen. So you want to get treatment if your child is injured or you suspect they're injured, but over-treatment sometimes as bad as under-treatment. Adolescents. They're risk takers. They're bulletproof. They can't be injured. They do all sorts of things that the older crowds learn not to do. Motor vehicles, sports, water activities. That's how they do it. Now, remember the ability of adolescents to under or over-report for secondary gain. Johnny, if you have signs of a concussion, we're not going to let you play football the rest of the year. Mom, I feel fine. Johnny, if you have signs of a concussion, you don't have to go to math class. Mom, I have a headache and I feel nauseated. Okay, same kid. So think about that and think about how you're going to get data. When do you worry? We've seen this list before, a few modifications here. But remember with kids, with adolescents, they're basically turning into adults. You're going to see the same signs that you see with adults. Again, loss of consciousness, altered mental status, perseveration, focal deficits, and so on. Treatment. Recognize that in a public setting, such as at school, you're going to be constrained by a protocol. Don't rage against it. It's just what's going to happen. Okay? In private, you can make your own decisions. The safest group with the best physiologic reserve are the adolescents. They can often be observed, and they're probably going to do fine. And frankly, as we'll get to at the end of this talk, what are they really going to do for you at the hospital anyway? I'll talk to you about that. It isn't much. There isn't a surgery or a medical treatment for concussion. What do I recommend? Rest with the head of bed elevated. With the head higher than the hips, that enhances venous drainage. Remember my Monroe-Kelly graph that had venous blood, arterial blood, brain, spinal fluid, mass. The brain is swollen a little bit. I raise the head of the bed when the patient rests. More venous blood drains out of the head to the heart with every breath. The thorax has negative pressure, pulling the venous blood out of the brain. And what happens? The brain swelling decreases a little bit. The patient gets better. Excellent trick. Avoid Valsalva maneuvers. Valsalva is the $5 word for grunting and straining. Don't let them grunt and strain. Gentle activity for 3 to 14 days. That means no sports, no big household chores, no weightlifting, things like that. And then a sideline test before they resume activity. What's a sideline test? The standard sideline test in, say, football or sports, you have the kid do 50 push-ups. You have them do wind sprints up and down the sideline. So, your teenager bonked his head somehow. You decided to watch him at home. You've been watching him for 3 or 4 days. He looks fine. He wants to go back and do whatever he wants to do. Do a sideline test. Have him run wind sprints around the house for 3 minutes. See if his symptoms come back. If they don't, you're probably all right. And then follow school and athletic performance from a distance. Why do I say that? I'll tell you a war story. I'm in Philadelphia at Children's Hospital, and there's this kid coming in for hockey-induced post-concussive headaches, and he's had every treatment in the book and nothing makes them better. Dad walks in. Dad is a monster. You can tell Dad lives, eats, sleeps, and breathes hockey. Dad loves hockey. Kid's sitting there, he's staring at the ceiling. And every question you ask, Dad answers for him. And Dad wants his kid back playing hockey. This kid's going to play in the NHL. This is what needs to happen. Get this kid better. Get these headaches gone. I get Dad out of the room, and then with my face turned away from the kid to kind of disarm him, I'm kind of washing my hands. Without even looking at him, I say, "You hate hockey, don't you?" Without thinking, he goes, "I can't stand it." Why did he have headaches? It was a way to get out of playing hockey. And his dad was never going to let him stop playing hockey. All right? So follow performance from a distance. Don't be suggestible. Is this hard for you? Is this easy for you? Mom and Dad will be disappointed if you don't do this. You have to do this. Follow from a distance and see what they do so you don't create your own outcome. Closed head injury by age group, adults. How do we hurt ourselves at our age group? Motor vehicles, do-it-yourself, equestrian. We used to joke that the Home Depot ad, "You can do it, we can help." We used to say it's "You can hurt yourself, we can help." And so whether it's, wiring or ladders or, around here riding horses, certainly. That's kind of what we do to hurt ourselves as adults. Same list of things to worry about. Note, I now have added in here blood thinners. And I have added one other category, alcohol, narcotics, and psychiatric medications. All right? So you have somebody that has bonked their head and they've got altered mental status. I can't tell you how many times a year I get called from an emergency room, "Mr. Jones hit his head and he's got altered mental status." What is Mr. Jones's blood alcohol level? "Oh, I didn't think to check that." "Oh, it's 220. Well, everybody I know with a blood alcohol level of 220 has altered mental status. Let's let him sober up for a couple hours, and then we'll see if he has a head injury, and Mr. Jones almost never does. So you want to think about those things in adults that you maybe wouldn't think about in other groups. Again, in public settings, work setting, you're going to be constrained by our protocol. On your own, again, think of what you did with the teenagers. Head of bed elevated, avoid Valsalvas, gentle activity. Now what I have here is 2 differences. One is a modified sideline test. Please do not take your spouse who is 58 years old and hasn't exercised in 38 years and have them do 50 push-ups or run wind sprints around the house for 5 minutes to see if they have a head injury, okay? It's easier just to call 911 first. So what you want to do is find an activity that they would do before the head injury and have them do it. And really, it might just be something as simple as walking up and down the stairs 5 times. Finally, closed head injury is a real health issue, but it's currently riding a wave. Don't get too excited. Overtreatment is as bad as undertreatment. We talked about radiation from CAT scans. We talked about stress worsening anything, suggestible patients where you can create your own outcome. A culture of fear. I will tell you in my family, and it's just for my family, I would rather raise a child that is confident, able to play hurt, and able to overcome problems via his or her own effort than a child that every time something bad happens retreats into a corner, consults a protocol, and waits for somebody to help him out. So I'll accept some risk of injuries, and my kids have had more than their fair share, in exchange for, when these kids leave my nest, having them confident and able to solve their own problems. You decide what's good in your home. That's not for everybody. All right? Knowing the warning signs. We've gone over multiple slides that show that. Know the demographics. Toddlers, adolescents, adults, elderly. There is little role for CNS or central nervous system imaging in closed head injury. We're going to do it anyway, okay? But realize that it doesn't really change the equation much. And then finally, this is just Poffenbarger's philosophy on life. You can greatly simplify your life and reduce stress by accepting a 99% outcome versus 100% outcome. Getting that last 1% of perfection is expensive, tedious, and painful. Accept a little bit of risk in your life. Accept that things may not be completely smooth. It's probably the way it was designed to be. Thank you very much.